Hey guys, this is Miss Garrison. I am recording the content from the Dysrhythmia review from Monday. Sorry it didn't record that day, but I see the red light, so I do believe I'm recording now. I want to thank each and every one of you that was able to come on Monday and participate in the Zoom review on dysrhythmias. If you weren't able to make it, that's why I'm doing this recording. You have access to the handout. I sent it to the whole class on Canvas. It's also on your level 4 Facebook page. If you don't have a copy of the handout, just reach out to me. My email is wgare@dcc.edu. And I want you to know that the discussion board on Canvas is open. So let's proceed and go through this content. All right. Note to self, success in level 4. You have to prepare before you come to class. I know everybody has busy lives, but this is tried and true evidence that if you prepare and come to class knowing a little something already, you're going to understand it and it's going to be less daunting. It's a two-way street. The teachers and the students, we got to work together to make you successful. All right. So on to the first thing to discuss, and it's the conduction system. And this is an overview for you guys. Electricity starts in the SA node, and then electricity has to follow a conductive pathway. So very quickly down these 3 internodal pathways, just like the interstate, you know, from Louisiana to Mississippi to Alabama to Florida, down the internodal pathways, 1/10 of a second pause at the AV node, down the common bundle, and whoosh, down both sides of the ventricles. The inherent rate of the SA node, the sinus node that sits up high in the right atrium is 60 to 100 beats per minute. If for any reason the SA node cannot fulfill their responsibilities, the AV node can be the backup pacemaker at a rate of 40 to 60 beats per minute. And last but not least, the Purkinje fibers can put out impulses 20 to 40 beats per minute. So how are we going to assess this electrical flow in the heart? Well, we're going to look at our EKG paper. And on the next page, it's a better description of the ECG paper. But you see large boxes, and you see there's 5 small boxes in each large box. We'll look at this more closely in just a minute. But we're going to look at the tracing. The P, QRS, T. The P will indicate our atrial depolarization. The QRS is our ventricular depolarization. And very importantly, the T wave is our ventricular repolarization. So atrial depolarization, ventricular depolarization, and the T wave repolarization. And what are we talking about? I'm talking about the action potential. And you've all taken pharmacology with Ms. Quayle, and so you know, particularly antiarrhythmic meds work in the action potential. Sodium rushes in, calcium follows, potassium's on the inside of the cardiac cell and says, getting too crowded in here, and so it leaves. And then by the T wave, everybody's going back to their original places. So we're going to talk a lot about the downslope of this T wave as we go through the entire session. So what have we just learned? What's important for nurses to check? Electrolytes. In level 4, you got to know these electrolytes. Sodium, 135 to 145. Potassium, 3.5 to 5. Magnesium, at EJ, I know it's 1.8 to 2.2. You got to know calcium. You got to know your levels. By all means, go with the levels that are in your lab book. And now we have EKG leads. First off, what is a lead? A lead is just a view. A lead is a view. I'm just looking at a particular area of the heart. Am I going to test you? Lead 1 looks high lateral, Miss Garrison. No. Lead 2 looks down and left. Down and left, sorry, Miss Garrison. Lead 3 looks down and slightly or into the right. No. But if you want to have fun at work, you're going to learn this stuff. By virtue of me putting on electrodes, I wish I had some electrodes here. I apologize that I don't, but when real class rolls around, I'm going to have some. I'm going to put an electrode on my right shoulder, my right chest here, one on the left, one right here, and then one smack in the middle. By putting those 5 EKG patches on the chest, I can tell the monitor, look at lead 1, look at lead 2, look at lead 3, look at AVL, look at V1. Just saying. And this will really become evident in clinical, hands-on in clinical. So lead 1 looks left, lead 2 looks inferior, lead 3 looks inferior, down as well. What's this AVR, AVL, AVF? That stands for augmented voltage right, left, and foot. Augmented voltage right, it means the positive pole of that lead is up on the right shoulder. And we don't often monitor anybody in AVR. Why? Because electricity flows down and left in the heart. If I may back up to that picture of the conduction system, I'll show you that. Look at the direction of the electricity. It's flowing down and left, down and left. Lead 2. That's why we most often monitor people in lead 2. Lead 2 is a very, 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 very popular lead. Check it out. The V leads, the ventricular leads, the precordial leads. Where you put the little tabs for this is very important. Otherwise, you're going to get inaccurate information. On the next page, V1 literally says the placement is right sternal border, 4th intercostal space. V2, 4th intercostal space, left sternal border. V3, skip it, we'll come right back to it. V4, see, it is the mid-clavicular line, 5th intercostal space. Now backtrack to V3. V3 is smack in between V2 and V4. Likewise, we're going to forge ahead and go to V6, which is mid-axillary line, 5th intercostal space. And the little tab for V5 would be smack in between 4 and 6. Somebody had asked me via email last week, hey, Ms. Garrettson, are we going to look at 12-lead EKGs? We will, but we're going to look at that when we get to perfusion 2. This content is under perfusion 1. Perfusion 1, we're going to look at dysrhythmias. Perfusion 2, we'll look at acute coronary syndrome, heart attacks, my favorite. And then Dr. Udo is going to address perfusion 3, which is hemodynamics and shock. But perfusion is perfusion. And perfusion just means the heart as a pump is pumping well, systole, diastole, systole, 1/3 of the cycle, diastole filling 2/3 the cycle. If the heart is pumping well, then oxygen-rich blood will be delivered to all the vital organs of the body. So good perfusion looks like this. Your brain, you're awake, alert, and oriented. Your periphery, you're warm and dry, not cold and clammy. Your lungs, you're not short of breath. Your heart muscle, there's no chest pain there. Your kidneys, you've got excellent urine. And I'm not talking 30 mils an hour. I'm talking 0.5 mils per kilogram of body weight. So a 100-kilogram patient, 30 mils of urine an hour ain't going to cut it. It's 50 mils. All right. So when you see the little tech come to do a 12-lead ECG, they're literally going to put the 4 limb leads on. And even though I said the placement here, here, there, and there, that classifies limb leads. You also could put it on the actual limbs, your right arm, your left leg, your right leg, and these 6B leads. Between those 10 electrodes, we can look at 12 different views, 12 different leads. All right, perfect. And that's where your landmark is for the V1, everything on your handout, it's all spelled out. Now let's take a few minutes to look at this EKG paper. Each large box contains 5 small boxes. The horizontal axis is time. What kind of time did it take for that impulse to travel from the SA node to the AV node and then into the ventricles? Each small box is 0.04 seconds. And look what I have here. I got a calculator, because it's helpful to have a calculator when you're doing these things. You know what else is helpful? To have a piece of paper. To have a piece of paper. A student gave me feedback on their eval form and said, you know, Miss Garrettson, I took a little course at EJ and they made us have a small slip of paper when we're measuring our PR interval, our QRS, and our QT. I wholeheartedly agree. And then you can hold that and it's much easier to see the boxes. So by all means, grab your piece of paper. All right, so each small box is 0.04 seconds. So then 1, 2, 3, 4, 5 small boxes times 0.04 is 0.20. So each large box is 0.2 seconds in length, in time. Now, the vertical axis, each box up, is the amplitude. That's how we're going to discern ST elevation or ST depression. And we'll get to that in perfusion too. ST elevation, MI, STEMI in the ED is one very cool patient to have. And not that I wish it upon the patient, but if we can catch that pretty quick, man, we can fix them. Bing, bing, bada, bing. And we're not walking to the cath lab. We are briskly, it's a brisk trot. It really is. It's very cool, because we are going to save your life. All right, so the P wave should be nice, smooth. And then we see the QRS. QRSs won't always look exactly like this. And then we see the T wave. So from the beginning, the P wave indicates atrial depolarization. And from the beginning of the P wave to the beginning of the QRS, this triangle in the middle, it's called the QRS. Sometimes you have a first little downward dip would be the Q. Sometimes you don't, but we're still going to call it a QRS. So from the beginning of the P to the beginning of the QRS, that is the PR interval. And the normal range would be 3 to 5 small boxes across, 0.12 to 0.20 seconds. Okay, now the QRS, that's talking about transmission through those ventricles. I want it to be nice and tight. I want it to be skinny. I recognize that twice on the handout, once we say less than 0.10, and another time we say less than 0.12. Either one is correct. Either one is correct. I think I've already addressed that question on the discussion board. So a nice skinny QRS to indicate that it was transmitted quickly, like it should be. First little downward dip is Q. This upward stroke is the R wave. Believe it or not, everything above this baseline is the R wave, and anything below it, there's my S right there. Measure it to where the S comes back to baseline. So my QRS is measured from the beginning of the QRS to the end. Now check out this flat line. It is the ST segment. And lo and behold, the line in between the P wave and the QRS, it's on the same isoelectric line. That PR segment sets the tone for that ST segment. And this one's perfectly normal. It's fine. There's my T wave, ventricular repolarization, where potassium's going back into the cardiac cell and sodium and potassium are going back outside. And that's a relative refractory period. Leave me alone. It's like you're a nurse and you just worked a 14-hour shift and you walk inside your house and everybody's like, hey, like, just give me 5 minutes. Just give me 5 minutes and then I'll be okay. That's the relative refractory period. If a big bad PVC comes and hits you right here, we could have ourselves a problem. And it's called VTAC or VFib and a code blue. All right. Ooh, the QT interval. First off, let me thank publicly our Dr. Kim Udo, who is my classmate from nursing school, May of '82. She put together this beautiful pre-class workbook, and so I took bits and pieces from it and my handout and merged it into your handout for today. You will see when we start class next Thursday and Friday, August 20th and 21st, that it's going to be posted as 2 separate handouts. So I thank Dr. Udo. Her motto in teaching is share everything always, and she is one of my idols. I really, really, really love Dr. Udo. All right, so QT, 0.38, Later on for me, you're going to see 0.36 to 0.44, but it's rate dependent. We're going to look at lots of examples. Okie doke. So someone on their eval, and I appreciate the feedback so much, said, man, you go through these EKG strips so quickly, Miss Garretson. I'm telling you that if you sit and study these complexes and measure your intervals with the material that you have in this handout, if you keep reading and reviewing and studying, you are going to be able to interpret any rhythm. I'm not going to give you a fish. I'm going to teach you how to fish. That's my goal. All right. So let's look at this EKG strip box. Number 1 is the P wave. Number 2 is the PR interval. Number 3 is the QRS. 4 is my ST segment. 5 is my T wave. And 6, from the beginning of the QRS, that first little downward dip, to where the T comes back to baseline. That is my QT interval. Let's go ahead and measure these intervals right now. How many boxes from the beginning of my P wave to the beginning of my QRS for our PR interval? 1 box, 0.04, 0.08, 0.12. It's about 0.14. It's about 3.5 boxes across. What's the width of my QRS from the beginning of the QRS, from where the Q first went down to where this R comes back to baseline? I'd call it about 0.06 to 0.08. They're both correct. And last but not least, the QT interval here from the beginning of the Q to the end of the T wave. See that? Let's see. I'll count that half box in just a sec. 1, 2, 3, 4, 5, 6, 7, 8.5. Handy dandy calculator. 8.5 times 0.04. Up, got to turn your calculator on. 8.5 boxes times 0.04, 0.34 seconds. Hello. And I could do that in my head, but still, just want to double check. Excellent. And it would be nice if you took this piece of paper and I'm gonna draw this for you right now. I'm gonna try to demonstrate this for you right now. Next time I'm gonna be prepared with an easel. Everybody see that complex? Let me show you how I'm gonna mark from the beginning of the P wave to the beginning of the QRS with my little piece of paper. This is my little piece of paper. Voila. You see that? You see how I mark those lines? Well, now what am I going to do with those lines? I'll show you. I'll show you what I'm going to do with those lines. I'm drawing a little box. You see these two little marks that I made? Now I can bring it to my EKG paper and I can see how big it is. Bring the lines down to your paper like a ruler. And you can see that that's a box and a half across, 0.06. So the lines that you mark from the beginning of your P wave to the beginning of your QRS, bring it down to just an empty box on the EKG paper and you can see the boxes more clearly. I'd be happy to try to clarify this for anybody. Okay, moving on. That ST segment is going to be really important when we look later on in perfusion to see if there is an injury pattern, ST elevation, or an ischemic pattern, ST depression. Neither is good, but we can fix them both. And that's why I love being a cardiac nurse for 38 years. QT interval, check it out. QT intervals are rate related. The slower the rhythm, the longer the QT. The faster the rhythm, the shorter the QT. And guess what? What's worse? A short QT or a long QT? A long QT ain't good. A long QT is not good because that increases the vulnerability of that downslope of that T wave. Remember, the heart just wants to chill during the relative refractory period. All the electrolytes are going back to where they're supposed to go. So if a big bad PVC hits you on the downslope of a T, you got yourself a code. And I ain't making that up. All right. So now EKG rate. Personally, my favorite way to determine the rate on the EKG is to read the monitor. The heart rate is 130. Okay, but you can't always believe what you read. So we print out a strip. How often should we print out the strip? 8 a.m., every 4 hours, noon, 4 p.m., 8 p.m., midnight, 4 a.m., and 8 a.m. again. And we measure the PR interval, the QRS, and the QT. Because we want to look at trends. And if everything's hunky-dory fine, well, hello, we're cooking with Crisco. But if something's trending in a bad way, you got to pick up the phone. Hey, Dr. Bourgeois, this is Wendy calling. We got Houston, we've got a problem. And when you do call that doc, be ready, be armed and ready with a patient assessment, a set of vital signs. You're looking at your labs on the computer as well as your meds, because the doc is going to start asking questions. How does the patient look? What's their blood pressure? Are they having any symptoms? What meds do I have them on? What's his potassium? What's his sodium? What's his calcium? What's his magnesium? All right. So the first method that we could use with the EKG paper, it's called the 6-second strip method. And guess what you need for that? A 6-second strip. How many boxes across would it take to determine if this was a 6-second strip? Well, if each big box is 0.20, it would require 30 of them. 30 times 0.20 is 6 seconds. And 6 seconds goes into 60 seconds 10 times. So we can look at this 6-second strip. Let's me and you right now confirm that this is a 6-second strip. One big box, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Woo! 30 boxes times 0.20, that's a 6-second strip. So now I can count the number of complexes times 10, and that's my heart rate. Let's go. 1, 2, 3, 4. Whoa, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 times 10, it's 130. Now, we're going to look at sinus rhythms today, normal sinus, sinus brady, sinus tach. We're going to look at some atrial rhythms and some ventricular rhythms. But this is sinus tach. Why, Miss Garrettson? I mean, I don't mean to jump ahead of myself. Well, because it's fast. It's greater than 100. Remember, the SA node kicks out 60 to 100. But I still know it's a sinus rhythm because I got that nice, pretty uniform P wave. That nice uniform P wave tells me it came from the same place, the SA node. When the P waves are nice and uniform, they came from the same school, the school of the SA node. So, and you will see, if you've already looked through your handout, that there is a systematic overview that we utilize. And that is, number 1, what's the rate? It's 130. Number 2 is, what's the rhythm? It's very regular. Woohoo, good. Nice uniform P waves. It's sinus, but it's fast. Sinus tach. What? And that's as simple as it is. But there's different methods to also calculate the heart rate. The 6-second strip is great. I love it. It's really good for AFib because AFib, you can't use the other methods. And I'll tell you why. Because it's so irregularly irregular, the other methods aren't going to work. I will explain why. Big box method. You see these large boxes? Look at this same example. Look at the third complex. You see how that QRS literally falls on the heavy line? Well, let's count the number of large boxes in between this R wave and the next R wave. I see one large box, I see two, I actually see about 2 1/4. So written as a decimal, 2.25. You got to remember this number, 300 for the large box method. So 300 divided by 2.25, what do you know? That heart rate's really, or we could even say 2.2. 300 divided by 2.2, heart rate's about really 136. Now on a test, am I ever going to say the rate of this EKG is A, 130, B, 136? No, indeed. No, indeed. Because it doesn't matter if it's 130 or 136. But I'm just saying there's more really accurate, dead-on ways to calculate a rate. It's in the 130s. You know, it's all relative. So that's my large box method. Let's look at the little box method. How many little boxes did we say was in a big box? 5. So what's 300 times 5? 1,500. Hello. I'm like, what? You know, sometimes I'm slow. I'm book smart, but sometimes it takes me a while. So now I remember the number 1,500 divided by the number of little boxes in between the R waves. Well, let's look at that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Let's try that. 1,500 divided by 11, 136. That heart rate is 136. Now, when I give you test questions, and I will give you a practice quiz as a ticket to class for next Thursday and Friday. Just fill it out to the best of your ability. I bet you're all going to nail it. But I want you to have it because that's the first thing we're going to go over. This is sinus tach. And one thing you're going to learn about sinus tach is usually it's not a problem. It's usually just in response to something like, oh man, their fever's back. Or they've had vomiting diarrhea for a couple of days. They're going to need some fluid. And it's all about that equation, and it's written in your handout, and you already know it. Cardiac output is equal to your heart rate times your stroke volume. Cardiac output. Dr. Udo is going to attack this. It's the amount of blood pumped each minute, and a normal cardiac output is 4 to 8 liters. So envision 2 2-liter Coca-Cola bottles. That's your cardiac output each minute. And hopefully perfusion is the pump is working well, and that oxygen-rich blood is perfusing all the vital organs. Your brain, awake, alert, and oriented, not, honey, I feel a little lightheaded. Or your lungs, you're not short of breath, and so on and so on. So sinus tach, treat the cause. Fever, Tylenol, acetaminophen. If you're at exercise, leave them alone. They're supposed to increase their heart rate. If they're dry, give them fluid. If they're hurting, give them a pain med. Okie dokie. And last but not least, there's this memory method. You just got to remember these crazy numbers. 300, 150, 100, 75, 60, 50, 43, 37. Let's do it. Start on a heavy black line. Go to the next big line. 300, excuse me. Yeah, that's right, 300, 150, 100. Well, this heart rate is somewhere between 100 and 150, but much closer to 150. It's 136. Practice will make perfect, and we'll apply that throughout the next couple of hours. So to determine the heart rate, find the R to R interval. This is a really nice place to show you something about the QT interval. Let's look at this example. And see the markings on the EKG paper. Right here to right here, that's 30 boxes across. Do not assume that an EKG strip is a 6-second strip. You, your level 4 student, yourself, you have to count 30 boxes across to determine, oh, this is a 6-second strip because I count 30 boxes across. So that's the first note to self. Let's look at this. P wave, QRS, T. P wave, QRS, T. So you see this R to R interval, this R to this R. You see the beginning of the QRS to the end of the T. Do you see how the QT interval is actually half the length of the R to R interval? That's a good thing. When that QT is getting long, my friends, we are assessing and we are picking up that phone and we're gonna save the day. I'll tell you a little story about a real life scenario, and the patient did not have a good outcome. And it was after we had left clinical and we did everything right, but whoa, it was something. I'll never, ever, ever forget it. But now, not every little P wave is perfect and beautiful. What would I like it to look like? I'd like it to look like that, nice, smooth. Sometimes a P wave can be a little notched or peaked or upside down, inverted. But as long as each P wave is the same, then it's fine. That's cool, no problem. QRS is the same thing. Not every QRS complex is going to look exactly the same. Am I going to say, name this interval? Big Q, little q, big R, little r. No, not at all, not at all. I just want you to be familiar that each of these is a QRS. Wait, Ms. Garrettson, that one on the top left says QS. It's a QRS. So is this. Notice the Q would be the first downward dip. And then the S is below the baseline. There's really even no R here, but we still call it a QRS. Little bitty Q wave there. There's my R wave. Where would be a perfect one? This one, they're all perfect. They're all fine. That Q's a little deep. That's an R wave, but you with me? So the R is the first upstroke. Everything above the baseline is the R, and the S is below the baseline. Just a little lagniappe, certainly not going to test you on it, but you see the bottom row, the fourth one. You see the two R waves. This is a bundle branch block. And all that meant was your impulse was coming down the common bundle, going to the ventricles, and then when it hit the right bundle, went, got stuck like a brick wall. Why? Maybe a little coronary artery disease. It's really kind of no big deal. That's just a little right bundle branch block. It's all good. So all of these waves are referred to as QRS complexes, and it indicates ventricular depolarization, which hopefully produces a ventricular contraction, which, my friends, is your pulse. Awesome. ST segment, as I said, we are going to look at ST elevation, the letter B, and ST depression more in perfusion 2. This is very hard to read, but let's look at the back here. That's the P wave, the QRS, and that's the T. Sometimes the T can be tall and tented, and you've learned that's probably some potassium hiding out. I absolutely love this EKG strip right here, labeled artifact. What should the nurse do when they see this following rhythm? A, call a code. B, defibrillate the patient. C, go check for looseness of the electrodes. C, the answer is C. They're just moving around. They're trying to get comfortable. They popped the lead. We're going to go in and we're going to figure out what's going on. And again, at the bedside monitoring, they're probably only going to have those 5 electrodes on. The limb leads, that can be on the upper chest and lower chest, and 1 V lead, maybe 6, maybe a couple of V leads. A 12 lead would be just a snapshot in time where the person comes, puts 10 electrodes on, and that's a different story. But this is artifact. They just popped a lead. Now it's a good time as any to mention infection control practices on the unit. When the patient in CCU bed C gets discharged and we disconnect them from their monitor and we're getting a new admit from the ER, what do we have to do? We need to clean that room. Now, housekeeping's going to come and get it all nice and beautiful and ready. But if it's a fast turnaround, I'm telling you, nurses, you put your gloves on, you get your antibacterial wipes and bactericidal stuff and start wiping down those wires. Because if I'm the new admit in bed C, I want everything to be nice and clean and fresh when I get there, especially these days. QT intervals are rate related. Let's look at this strip, and we'll look at this strip again. It is 30 boxes across. I already counted it. You can count on your own. Let's count the number of complexes. 1, 2, 3, 4, 50-ish. Let's do the large box method. 1, 2, 3, 4, 5, 6.5. Whoa. So 300 divided by 6.5, that heart rate's really 46. Ooh. So I'm just saying, the slower the rhythm, the longer the QT. So when you've got a slower rhythm, let's count this QT interval from the beginning of the QRS to the end of the T, right there. Well, that's 5 small boxes, 10, about 15, to be honest, maybe 15 or 14. 14 small boxes times 0.04. That QT is 0.56, getting a little long. If it was only 0.48 at noon and now it's 4 o'clock and it's 0.56, I'm calling Bourgeois. I'm calling him. I'm calling him. First, I'm going to go check my patient who's probably fine. I'm going to have my medication administration record, my MAR, my labs all front and visible so I can start answering those questions. And I bet you Dr. Bourgeois is going to make some sort of a change. That is some ST depression. We'll talk about that more in perfusion too. It indicates cardiac ischemia. Might need a little nitro. All righty. And then here's my sinus tach. And the whole purpose of this is just to say that this QT interval is going to be shorter because the rhythm is faster. If I measured this QT from the, I always try to find the beginning of a line. Don't really see one here. About 4 boxes there. 5, 6, 7, 8. Maybe it's about 0.32. So the faster the rhythm, the shorter the QT. And why is that QT interval so important? I've said it a gazillion times, that refractory period. You do not want to mess with the downslope of the T. Otherwise, you will have a code. All righty. So here's our systematic overview. What's the rate? What's the rhythm? Is it regular or irregular? Is there a nice uniform P wave each time? Does each P wave have a QRS? What's the PR interval? Is it between 0.12 and 0.20? What's the QRS? Is it nice and skinny? Is it less than 0.12? And what's the QT? Is it normal range? Remember, it should be less than half the distance between the R to R. And name that rhythm. Well, this first rhythm, the rate is 50. The rhythm is very regular. Very regular. Very regular. That's when you take your piece of paper and you mark the R wave to the R wave, and then you just slide your paper across. Ah, that's very regular. Nice uniform P waves. QRS is skinny. QT's long. I'm not surprised. It's a real slow rhythm. Sinus Brady. And we haven't even gotten to the sinus rhythms yet, but we're getting there. Ooh, I love this strip. I love it. What do you think that heart rate is? Now, I can't see a show of hands right now, but how many of you said 30-ish? And you're wrong. It's not a 6-second strip. It is not a 6-second strip. So therefore, I can't use the 6-second method. Let's use the large box method. There's an R wave. Let's count the number of large boxes between this R wave and the next R wave. Well, it's about 1, 2, 3, 4. Calculator. What is 300 divided by 4? 75. That, my friends, is a normal sinus rhythm. Why? Because the rate is 75. Between 60 and 100, the rhythm is very regular. I've got nice uniform P waves that came from the school of the SA node. PR interval is good. What is it? 0.04, 0.08, 0.12, 0.16. Perfect. My QRS nice and skinny. 0.06, 0.08. QT, let's count it. 1, 2, 3, 4, 5, 6, 7, 8. 8 times 0.04 is 0.32. We're fine. Woohoo! Normal sinus rhythm. What should the nurse do? Leave them alone. If it ain't broken, don't fix it. Let's do this example. I'm thinking this is not a 6-second strip, so let's use the large box method again. 1 large box, 2, 3, 4, 5 1/4 almost. So what is 300 divided by 5.25? That heart rate is 57. So it's not 40, it's about 57. Let me ask you a question. How's a patient going to do with a heart rate of 57? They're probably going to do great. They're probably going to be fine with a heart rate of 57. That rhythm is very regular. P waves are nice and uniform. The PR interval, you can count it. It's about 0.16. My QRS, I'd call that about 0.08. My QT, I call about 0.40. Name that rhythm, sinus Brady. Lovely, lovely. Let's do this one. Again, this is not a 6-second strip. So let's count the number of large boxes. Here, the second complex QRS fell on a heavy line. So let's start there. 1 large box, 2, not quite 3, about 2.8 boxes. You know, it's not quite 3. So what's 300 divided by 2.8? 107. What? That's sinus tach. Is there fever coming back? Man, is he getting hot again? I tell you, I don't even need a thermometer to know when your fever is coming back. You get tacky. You get tacky. So my rate is 107. My rhythm is very regular. The P waves are very nice and uniform. My PR interval, 0.04, 0.08, 0.12, 0.1, about 0.16. My QRS, about 0.06. My QT, 1, 2, 3, 4, 5, 6, 7, 8, about 0.32. Name that rhythm, sinus tach. Oh, wait. Yeah, sinus tach. It was a rate of 107. Okay. Now let's get into the real nitty gritty. What rhythms are you responsible to know for purposes of test 1? Well, I follow the NCLEX blueprint. Normal sinus rhythm, sinus Brady, sinus tach, AFib, SVT, PVCs, VTach, and VFib. Are we going to discuss more rhythms today? Yes, we are. But that's what you're responsible for knowing. So here's normal sinus. And I know what you might be saying. You might be saying, geez, Ms. Garrison, that strip is a little light. Are the strips on the test going to be easily legible? Yes, indeed. Absolutely, positively. Notice the markings on the paper from there to there. That denotes your 6-second strip. So let's not count this guy on the end. For my 6-second method, I would say my heart rate is 1, 2, 3, 4, 5, 6, 7, 80-ish. But it's almost 90-ish. You can really tell. Large box method, 1, 2, 3 1/3. So what's 300 divided by? It's about 90. That heart rate's about, it's closer to 90 than 80, to be honest. But it's a very regular rhythm. The P waves are uniform. The QRS is skinny. And my QT is fine. It's certainly, you could see the beginning of the Q to the end of the T. That QT is definitely less than half the distance between the R to R. Isn't that something? All right. So what do we do for normal sinus rhythm? Continue to monitor your patient. Leave them alone. If it ain't broken, don't fix it. Now, sinus Brady. We've already looked at this strip. This is a rate of 50. Actually, with the large box method and the small box method, we determined that that heart rate was 46. So the rate is slow, but it's still coming from the SA node. How do I know? Because of the nice uniform P waves. The nice uniform P waves before each QRS. I do have a little ST depression going on. My P waves are uniform. My PR interval is good. My QRS is still nice and skinny. My QT is getting a little long because it's a slower rhythm. Significance is this patient's got a heart rate of 46. Now, who are we treating? We treating the monitor or are we treating the patient? We're treating the patient. So you go in. Now, how will I know to go in? Well, when we put our patients on the monitor and put the EKG pads on, we set the alarm. We set a high rate alarm and we set a low rate alarm. If normal is 60 to 100, I always set my high rate alarm at 120 and my low rate alarm at 50. So the alarm would have sounded. Professional Issues Day, it's one of my favorite days, and y'all are going to get to do these amazing poster presentations. And one of the topics is going to be alarm fatigue. It's real. And patients die because of alarm fatigue, where the alarm was going off, but the nurse just didn't hear it. Why didn't the nurse hear it? Because they're a bad nurse? Absolutely not. Because they're exhausted, because they're overwhelmed, because of staffing shortage, lots of reasons, because of false alarms, lots of reasons. So we got to work around that, because if my alarm goes off, I hope you come in and check me. More importantly, if my brother or my sister or my mom or my daddy's alarm was going off, I'd want you to go check them. All right, so this is a slow rate. We said that it's 46. Very regular rhythm. P waves are beautiful. Everything looks great. But we got to think about that equation. Cardiac output is equal to heart rate times stroke volume. If your cardiac output is dipping, it might be because it's a slow heart rate. That's what's going on. You know, it could be that. But check your patient. If they're warm and dry, awake and alert, denying complaints, well, then they're fine. Their cardiac output is not compromised in any way, shape, or form. So that's good. What are the most common causes? Am I going to test you on common causes? No, I'm not. We all know that well-conditioned athletes have a slower heart rate. Their heart muscle is better conditioned and doesn't have to beat as fast. Classic in the hospital, vagal maneuver. Patient finally gets out of the unit, gets transferred to the step-down tele unit. They finally have a private bathroom, and they go to the bathroom. They strain on the toilet. Code blue, room 246, and the code team arrives and sees the patient on the floor in the bathroom. I know what happened here. They were straining to have a bowel movement, which is why Colace, I think, should be called a cardiac med, the stool softener. Just kidding. But I don't want people straining on the toilet, because classically they Brady down, and if they get symptomatic, they're going to fall over. Is that really a code? No, but the nurse may have been seeing the patient on the floor, panicked, call a code. I'd rather you panic and call a code than not call a code, for sure. But what that happened there is they vagal down, and we want to prevent that. Very, very, very common. Other things can cause it too: hypoxia, hypothermia. But what do we give patients? Medications. What have you learned in pharmacology? Beta blockers, calcium channel blockers. They all slow down the heart rate. And guess what? That's the purpose of the medication. So I'm no physician. However, what should the magic dose be for that beta blocker? What about that metoprolol 50 milligrams? Is that the best dose for a patient? The doc wants to put you on the most minimal dose to decrease your heart rate, because he wants your heart to chill a little bit, but they still want you to perfuse. So as long as you can ambulate, cerebrate, and urinate, you're perfusing. As long as you're able to think, walk, and go to the bathroom, we're good. It means you're perfusing your brain, your body, your kidneys. So that's a good way to think about it. If somebody's getting super symptomatic and their heart rate's dipping too low, well, then we have to adjust the dose of the medication. Simply that. All right. Now, I know you guys learned about DIG. And have you ever heard that it's classic to hold the DIG if the patient's heart rate is less than 50? This is where I say, wherever you land your first job, know your hospital, know your policies, know your doctors. Dr. Dugan would be talking to me in an unpleasant tone if he knew I held the DIG for a heart rate less than 60. He's going to give me specific parameters of when he wants me to hold that DIG. So establish a rapport with the physicians and you'll have a much happier life, trust me, because we are the eyes and the ears for the docs. They're there, you know, 5 minutes a day and we're there 24/7. So when somebody has bradycardia, they may become symptomatic. They may not. If it ain't broken, don't fix it. But if they do have symptoms of decreased cardiac output, like, honey, feel lightheaded, cold and clammy. If a patient hit the call button, nurse, I feel lightheaded. I'm in the room. I'm going in. The first thing I'm doing is I'm walking to them. How you feeling? Feel a little weak. And as you go to touch their arm to take a manual blood pressure, you feel that they're cold and clammy. You're like, uh-oh, this is symptomatic. I'm thinking a little atropine, but you know, you got to have your standing order. For testing purposes, if you have someone with symptomatic bradycardia, I give you the green light to give 0.5 milligrams of atropine, IV push fast. Note to self, the IV, night nurses, day nurses, we are on the same team. And that's the team of the patient to provide the optimal outcomes for the patient. Please leave me a patent IV. Check your IVs before you leave, particularly if it's a central line, if it's a right IJ triple lumen or a left upper arm PIC line. 3 lumens, every lumen, every time, two-way street. I want it to flush and give me a good blood return. Never leave your shift without making sure your lines are patent. Because when your colleague's going to need that line, they need it to work. They don't need it to be occluded. Okay. Atropine. Sometimes a doc would order dopamine or epi, but probably not. Transcutaneous pacer. Where do we get that, Miss Garrison? Well, I'm here to tell you. On the top of the code card, which is in every unit, in CCU I can visualize 2 of them, there's a machine on the top of that card. And it's called the defibrillator, but I like to call it the 4-in-1 special because when we put the multifunction pads on the patient's chest, literally here, front, back, you know, over the heart, and they're literally labeled front, back, we can hook those multifunction pads into the machine and do one of 4 things. Monitor the patient. Heck, we could defibrillate them. We could synchronize cardioverter them. I'll explain those 2 things in a bit. Or we could flick the dial all the way to the green and transcutaneous pace, TCP. Break the words down. Through the skin. What? I am pacing through the skin? Yeah. And literally, you could get that machine and transcutaneous pace them. So for symptomatic bradycardia, there's 2 correct options. Atropine, 0.5 milligrams, and transcutaneous pacing. But which one can you get your hands on the quickest? That's the one that you use. It's probably going to be the atropine. Probably going to be the atropine. All right. But if they're asymptomatic, leave them be. We know our patients in the units are on beta blockers and calcium channel blockers. We know when they fall into a deep sleep that their heart rate's going to dip down. That's why I am a spoiled CCU nurse and I love my monitor. I can see that my blood pressure is 124/68. I can see that my O2 sats are 98%. I'm not going to wake him up. His heart rate dipped down to 48, but I'm going to let him sleep. All right. Sinus tach. This is where it's faster than 100, but we're going to treat the cause. Here is our markings to indicate a 6-second strip. 15 boxes here is 3 seconds. Again, so we're not going to count these guys on the end. So this heart rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 120. Heart rate's 120. It's faster than 100. Nice uniform P waves. Sinus tach, baby. My P waves are uniform. My PR interval is fine. It looks like it's about 0.12. My QRS is skinny, 0.04, 0.06. My QT is rate dependent. I know it's kind of hard to see. Yeah, that one looks a little different than this guy. The QT is shorter because it's fast, and that's cool. But what's going on? Are they feverish? Are they in pain, anxious, hypoxic? little CHF exacerbation, acute MI. Now, I'll be honest. The only time I worry about sinus attack is when it's in the midst of an MI. Because if you've had a heart attack and loss of some heart muscle, remember the equation, cardiac output is equal to heart rate times stroke volume. Stroke volume is just the amount of blood pumped out with each beat. Should be about 70 to 110 mils. If your heart's too pooped to pump, your stroke volume is going to go down. So the first thing God's going to do to us is make us tacky to try to maintain that cardiac output. Cardiac output is equal to heart rate times stroke volume. So if my stroke volume dipped down to 50 and now I'm tacking away at a rate of 120, let's do the math. Heart rate of 120 with a stroke volume of 50, ooh, that's still 6-liter cardiac output. And that's nice compensatory measure, but that ain't gonna be able to last too long. Dr. Udo is gonna talk more about that in Perfusion 3. All right, so sinus tach. In the event that they get a little lightheaded, cold and clammy, weak, chest pain, we need to intervene. We need to slow it down. Treat the cause. Tylenol for the fever, acetaminophen. If they're dehydrated, they need fluid, pain med, anti-anxiety med. Cut out the caffeine. How many cups of coffee did you have today? 7. Switch to decaf. This is a problem. All right, so we're finished sinus rhythms. We've looked at normal sinus rhythm, the rates between 60 and 100, nice uniform P waves, leave it alone. Sinus Brady, if it's symptomatic, atropine's our drug, 0.5 milligrams, IV push, fast. Hey, after we give the med, what do we need to give? A 10 cc saline chaser. I'm not talking about like a little chaser like that. I'm talking about a saline syringe. If it's a central line, check your policy. You very well may need to flush it with 20 mils of saline. Now on to atria, atrial rhythms. You know the atria, the upper atria, the right and the left atria, and the lower chambers of the ventricles. And yes, the SA node sits up high in the right atrium, but sometimes a little impulse can originate from elsewhere in the atria. And what's important about the atria is that blood, when it pumps from the atria down to the ventricles, that contributes 20 to 30% of our cardiac output. It's called the atrial kick, and that's important. The first atrial dysrhythmia that we're going to look at is a PAC. Am I testing you on that? No, but I want you to see it anyway. Let's look at this strip. This is a 6-second strip. Systematic overview, Miss Garrettson. The heart rate is 1, 2, 3. Ooh, he came early. 4, 5, 6, 7. It's 80-ish. It was regular except for this early guy. Hey, you just got out of level 3, huh? That beat came early. He's premature. So pick it up from the beginning. A nice P wave, QRST. P wave, QRST. P wave, QRST. Whoa, he came early. He was supposed to come there, but he came early. And by the way, look at that P wave. Man, that guy's a little more pointy than the other guys. He didn't come from the SA node. He came from elsewhere in the atria. The presence of a P wave tells me that it came from the atria, but nice uniform P waves came from the school of the SA node. School of the SA node, that's my little Catholic school kids. You see that? This little guy, public school, came from elsewhere. Just kidding. My husband went to public school and he's the smartest guy I know. Anyway. The rate is that of the underlying rhythm. So the rate is 80 here. The rhythm's just a little irregular because of that early beat. The P wave on that PAC, it's funky looking, it's different looking. And that PR interval might actually be shorter. But this is a nice, benign, beautiful rhythm. No problems. I'd call it normal sinus rhythm with a PAC. Now, am I going to call anybody or do anything about this? Absolutely not. But I got my eye on it. I do. Because too many cooks in the kitchen spoil the gumbo. And we'll see that when we get to AFib. Now, let's talk about patterns. If every other beat was a premature atrial contraction, if every other beat was a PAC, that would be called atrial bigeminy. If every third beat was a premature atrial contraction. That would be called atrial trigeminy. And if every fourth beat was a PAC, it would be called atrial quadrigeminy. Too many cooks in the kitchen spoil the gumbo. What causes PACs? Tension, stress, nursing school, alcohol, caffeine, tobacco, electrolyte imbalances, meds, treatment. There's no treatment. It's all good. Just decrease whatever's causing it. It's one of my favorite things to talk about, AFib. 2 words, repeat after me. Irregularly irregular. Atrial fibrillation. Irregularly irregular. Calculating this heart rate, the monitor says my rate is 90. 6-second strip says my rate is 90. Let's count it. 1, 2, 3, 4, 5, 6, 7, 8, 90-ish. The rate's 90. Well, that's good at least, because that ventricular rate of 90 is controlled because it's less than 100. That's an AFib with a ventricular rate that's controlled less than 100. Why can't I do the large box method or the small box method with AFib? Because it's irregularly irregular. You know, I don't have the luxury of a regular R to R interval. So you can only use the 6-second method here. All right, so we've established that our rate here is 90. The rhythm is irregularly irregular. There are no discernible P waves in AFib, just atrial fibrillation waves. There is no PR interval to measure. The ventricular rate can be controlled, less than 100, or uncontrolled. Which would you rather have? I'd rather have controlled, because the faster something is, we could get into trouble. Oh, sorry, this repeats itself. I got to remember to take that off of the handout. All right. QT might be very, very difficult to measure in AFib, so don't worry about it. Let me turn on the ceiling fan. It's getting a little warm in here. Okay. All righty. Significance. There's some important things you got to think about. Number 1, when the atria isn't contracting well and pumping that fluid forward down to the ventricles, you lose that atrial kick. That's 20 to 30% of your cardiac output. That's significant. 2, blood in the atria will just clot. I know you're in nursing school and you haven't watched TV for a couple of years now, but every other commercial is an anticoagulant. My doctor put me on Eliquis, you know, for my AFib, because when you're in AFib, and the problem with AFib, and I had a student share with me via phone conversation, I know AFib, Ms. Garrettson, because my grandparents in AFib, and despite all the meds and cardioversions that they've tried, they kept going back into AFib. It's one hard rhythm not to have come back to haunt you. So you lose your atrial kick, formation of clots, which can lead to a stroke. As a daughter of a stroke patient, I'm here to tell you that changes everybody's lives. We want to prevent that at all costs. You also want to think about how fast the ventricular rate is. In this example, we're good. We're good. The rate's only 90. And then, how long have they been in that rhythm? If they've been in that rhythm longer than 48 hours, well, the problem is they've had time to form a clot. And if I have no way of knowing that it's definitely been less than 48 hours, I have to go ahead and anticoagulate them. Simply that. So and let's talk about that. So lose atrial kick, blood clots, control the rate. That rate is already controlled. And how long have they been in this rhythm? Let me give you the first scenario. Look at this strip. Pretend this was a gentleman, a 65-year-old male named Frank, and he's going to his routine cardiology visit to see his doc. And the doc does an EKG and he goes, "Frank, you're in AFib." And Frank says, "What's AFib?" "Well, it's an irregular rhythm. Frank, how you feeling?" "I feel all right, doc." "Why, is something wrong?" "Well, I don't like this rhythm. It could make your blood clot and you could have a stroke." So Frank, what I'm gonna need to do is get you out of this rhythm. But I have no way of knowing if you've been in this rhythm for less than 48 hours. So I'm gonna send you home for 3 weeks on an anticoagulant. Then we're gonna have you come back in and we're gonna get you out of this rhythm. We're gonna do a cardioversion after you come back. I've had many students in the cath lab that got to observe a cardioversion. What's a cardioversion, Ms. Garrettson? Well, it's when we deliver a shock to the chest, but it's synchronized. It's synchronized with the patient's R wave. Well, what do I need to use for that? That 4-in-1 special defibrillator machine that sits atop the code card. So does cardioversion mean we're going to code the patient? Absolutely not. I just need the machine. So I roll the code card to the bedside, put the multifunction pads on, and then I synchronize. I hit the sync button, see the R wave highlighted, and then after 3 weeks of anticoagulation, we're going to be able to cardiovert this patient out of this rhythm. Of course, this procedure is led by the doc. It requires a consent, and I'll explain more when we talk about cardioversion. It's coming up in your handout. But there's Frank, our 65-year-old patient who came to see his doc. He's in AFib. He's asymptomatic. Do you think that doc could say, hey, Frank, I need you to go straight to the hospital? You think insurance is going to pay for a 65-year-old man that is asymptomatic, not having symptoms? Sadly, no. So we got to send him home on 3 weeks on anticoagulants. All right. So let's read on. We've already said that. We'll cardiovert him later. Causes. I'm not going to test you on causes. You get older, more common in men. COPD, hypertension, rheumatic heart disease, thyroid problems, all kinds of things. I'm not going to ask you the reasons. The patient in AFib can have no symptoms like Mr. Frank, or they could be saying, I have palpitations or I feel bad. It is the person in uncontrolled AFib, a faster heart rate, that is more likely to have symptoms. And I'm not going to lie to you, the reason they're having the symptoms isn't necessarily the AFib, it's the fast rate. So that's why we want to slow that train down with cardizem. If you've ever taken ACLS for rapid AFib, you want to go with cardizem, which is diltiazem. Okie doke. So the patient in AFib, if it is greater than 100, they very likely will have palpitations, fatigue, shortness of breath. Honey, I feel a little lightheaded. If that's the case, we need to act on that. So here's our treatment goals. Goal number 1, slow that train down. Control the ventricular rate first. I don't even have to worry about the clot by just slowing the rate. I'm not converting the rhythm. I'm just making it from an AFib rate of 148 to AFib rate of 90, which would be better. Cardizem would be our guide, diltiazem. You will learn, particularly if you are an ER nurse, that lots of folks come in with a rapid AFib into the emergency department, and the doc will order a cardizem bolus, diltiazem. Maybe 5 milligrams IV push or 10 milligrams IV push it slow. Watch that blood pressure. Put that nib on, set it for every 3-minute cycle, and keep your eyes on that blood pressure. Once we get a slowing in the rate, the doc will probably order a diltiazem drip, also called a cardizem drip. I love that drip. It's a 1-to-1. It's 125 milligrams in 125 mils, and it's measured in milligrams per hour. So 5 milligrams per hour is 5 mils on the pump. You gotta love it. You don't even need your calculator for that one. All right. So goal number 1, slow down the rate. Goal number 2, prevent clots. Has it been greater than 48 hours? If yes, then we absolutely must anticoagulate you. We've already talked about Frank. We sent him home on Coumadin, or I'll just scoot down to show you the name of these meds. It's on the next page. The Pradaxa, the Xarelto, or the Eliquis, and they're making new ones every day. Got to know those guys. All right. Send you home for 3 weeks on an anticoagulant. Well, what if they've been in the hospital, they've been in the rhythm longer than 48 hours and they're super, super symptomatic and the rate is really fast? Oh my God. Can I cardiovert them? Not without starting IV heparin first. And this is, I didn't mention this on Monday, but I'm very glad I'm mentioning it now. Think about this. A patient presents to the ER, rapid AFib, rate of 150, 170, very symptomatic. Honey, I feel lightheaded, have a little chest pain, short of breath. They're in a rapid AFib. If they've been in that rhythm longer than 48 hours and I can't discern, I cannot go ahead and do the cardioversion. I can't. Now, granted, the doc is ordering it. I'm not doing it. He's actually doing it. And I'm going to need a CRNA because we're going to need to put them, they're going to need to use a little conscious sedation in the form of IV push propofol or Dyrhythmia. What the doc could do is a TEE, a transesophageal echo. I did not mention this on Monday. You really need a little push of the Dyrhythmia. Hey, RNs, can you and I, is it within our scope of practice to IV push Dyrhythmia, propofol? Michael Jackson, rest in peace. The answer is no. A CRNA will do that. And it works fast, man. It works really, 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 really fast. That'll conk them out. We'll put the multifunction pads on. We'll select, but for the TEE, the doc will put a pretty good scope down their throat into their esophagus and be able to visualize the chambers of the atria and see the coast is clear, no clot. And if the coast is clear, proceed to cardiovert. So if it were an emergency and they were crazy symptomatic and we'd want to cardiovert, if they've been in that AFib longer than 48 hours, it would be malpractice not for that doc to do the TEE. And they would be at the bedside, very cool. We'd be watching the whole thing. The coast is clear, no clot present, we can proceed to cardiovert the patient. All right, and I've got those steps written down for you. I do want you to look up all of these meds. Apixaban, Eliquis, it's great meds. Twice a day, you can take it with or without food. The big myth about Coumadin is you can't have green leafy vegetables. It's not true. You just need to eat a consistent amount every day. All right. And in the hospital, you got to love those patient teaching handouts. They're fabulous. Whenever you're at clinical, go ahead and print that out. So looking at AFib again, this is a 6-second strip with the exception of this first strip because you see the markings for the 6-second strips. 3 seconds, 6 seconds. My heart rate here is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. That heart rate is 110. It's borderline controlled. The rate is 110. The rhythm, it's irregularly irregular. There are no P waves present. You can't call those P waves. Therefore, you cannot measure a PR interval. My QRS is still skinny, so that's good news. That's good. QT, man, it's really obscured to tell you the truth. I think I see it there, but not there. And it is a little faster, so if I could see the QT, it would probably be a little shorter than normal. Name that rhythm. This rhythm is AFib, atrial fibrillation. And the problems are, I've lost my atrial kick. I have the propensity to clot, and for a stroke. Now, this is a flutter. Check this out. Squint your eyes looking at that. You see the sawtooth pattern? Unlike AFib, atrial flutter can be a very regular rhythm. This R to R happens to be very, very regular. Am I going to test you on A flutter on test 1? Nope, I'm not. A flutter is a lot less common than AFib. But I'm here to tell you that there is an animal called AFib flutter. Swear to God, sometimes you see fibrillation waves and then the flutter waves. But I'm not going to test you on flutter. We would treat it exactly the same because the same set of problems exists. You've lost 20 to 30% of your cardiac output, which is your atrial kick. 2, when blood is just fluttering in the atria, you have a propensity of blood to clot. So all the same concerns. So my heart rate here, systematic overview, this is a heart rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 100-ish, about 105-ish. So it's borderline controlled. I actually see about 4 flutter waves before each QRS. So, dude, if my heart rate was 100, then I'd have 400 atrial flutter waves. That's a lot of fluttering. That's a lot of propensity to clot. So a patient, if they're staying in this rhythm, they need to be on a baby aspirin and highly likely an anticoagulant. Very important. Of course, there's always a bleeding risk with all that stuff. Man, oh man. No good deed goes unpunished, huh? So a flutter, you see the sawtooth pattern. There's no P wave to measure, no PR interval, excuse me, there's no P wave, there's no PR to measure. My QRS is still nice and skinny. Lots of different causes. I'm not going to test you on that. Hey, if your teacher in clinical is saying, what could cause that rhythm? Just say DIG toxicity. But make sure that the patient's on DIG before you say that. So let's stop and think. The most important consideration in any atrial dysrhythmia is the ventricular rate. Then we have to ask ourselves a question. Is the patient symptomatic? They'd likely be more symptomatic if the rate was uncontrolled. The faster the rate, the more the symptoms. Honey, I feel a little lightheaded. Oh, I'm cold and clammy. My systolic's a little low. And that's going to determine how we treat the patient. Now let's talk about synchronized cardioversion. Synchronized cardioversion. It involves the use of that defibrillator, the 4-in-1 special that sits atop the code cart. However, the shock's going to be synchronized with the patient's R wave. Simply by me and you, the nurse, pressing the sync button on that machine, we see the machine highlight the patient's R wave. The doc will tell us what joules to set, what juice to give them, the joules. The doc may order 100 joules, 150, 200, even on a biphasic defibrillator. Well, what's a biphasic defibrillator, Ms. Garrettson? Well, it's a newer model. Biphasic means it's 2 phases of electricity delivery. So we use lesser joules because it's delivered more efficiently. Versus the monophasic defibrillator. We might start with 360 joules on that one, but the doc is going to definitely determine the joules. Now, you think when you shock somebody and they're still awake that it's going to smart a little bit? Yep, that's why we have to have the CRNA at the bedside pushing the diprivan, the propofol. And their goal is that airway, baby, because that diprivan has a real quick onset and they're going to knock out pretty quick, but got to watch that airway. Many of you will go on to become a CRNA. It would be very, very, very cool. All right. So as long as that sync button's engaged and you're seeing the highlight of the R wave, we're good to go. What's nursing related care for cardioversion? They got to be on the monitor. They need a pulse ox. We have the non-invasive blood pressure cuff set up. Supplemental O2, not always necessary. The thing about supplemental O2 these days, new school of thought, they really don't need oxygen unless they're getting a little hypoxic. When their sats start dipping below 92%, that's when you'll see oxygen put on. You can bet your boots that anesthesia's got every trick in their little bag. The ambu bag, suction, code cart's available. We can cardiovert the patient through these multifunction pads. Don't put that pad over a pacemaker site. We'll talk about pacemakers more in class next, probably the week after. Not so much next Thursday and Friday, but the following week. So my 3-hour perfusion, 1 lecture, we're going to do 1 hour next week, 8:30 in the morning, 12:30 in the afternoon, and then again on Friday. And then the following week, we'll close it down with the rest of the 2 hours. So you'll get a little time to digest. But I encourage every single level 4 student to watch this video prior to class. I am trying to give you a gift, but I need you to open it up before class. What you put in the level 4 is what you're going to get out of level 4. You'd want to remove the nitro patches, of course, turn the machine on, press sync, look for the highlighted R wave, select the joules as prescribed by the healthcare practitioner, charge when ready. When we charge, it's going to sound like this. Boop, and then you know it's charged. And when that's done, before we discharge the shock, in a commanding voice, I want you to say, I'm clear, you're clear, we're all clear. And then discharge. Boom. So you're standing back and you're not getting shocked either. And then we reassess the patient. So that's how we would do synchronized cardioversion for Mr. Frank after 3 weeks of anticoagulation, or emergently after the coast was clear, after the TEE said, hey, no clot. Now, I bet a bunch of you are thinking, well, what if on the TEE they do see a clot? What do we do about that? Well, we ain't cardioverting them right now, because that would be sending that clot flying, and that could be a stroke. What we're going to do is put them in the unit on IV heparin. That's what we're going to do. Man, oh man, oh man. And when we're on heparin, we're monitoring the PTT. When they're on Coumadin, we're monitoring the PT-INR. Okay, let's talk about SVT, supraventricular tachycardia. Break the word down. Supraventricular. This came from above the ventricles. This is not a ventricular rhythm. It came from above, somewhere in the atrium, maybe even the AV node. And hey, what's that word paroxysmal, Miss Garrettson? Well, that's that second strip right here. A sudden onset, and then it suddenly stopped. The word paroxysmal means sudden. But let's look at this first example of SVT. This is a 6-second strip. Let's count the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. That rate's 180. It's fast. That's fast. Might that patient be having symptoms? Probably. Probably. What is the first thing I, as a nurse, could tell them to do? Go ahead and cough. Cough. Bear down like you're having a bowel movement. We want them to vagal. Here's a story. True story. Happened a couple of years ago now. Student Hannah Cunningham in the ER. I was with Hannah. We're in one of the holding areas in the ED. Patients on a stretcher, very, very symptomatic with a low blood pressure, so they're flat on the stretcher. 28-year-old Vietnamese female, precious, precious little girl, young lady. SVT, rate of 280. Was she symptomatic? Yes. She said 3 things in this tone of voice. I can't breathe. I don't feel good. My chest is tight. Hannah looked at me. I looked at Hannah. We proceed to reach for the multifunction pads. The ER doc is there. The ER nurse is there. She needs to be cardioverted, like bing, bing, bada, bing. And this is SVT. There's no clot problem here. The clot problem comes with the AFib. We put the pads on her, and all of a sudden the patient retched like she was going to vomit. Hannah retched, I retched. Nobody actually hurled, but by her doing that vagal maneuver all on her own, she broke the rhythm. 2 hours later, she was discharged per wheelchair with instructions to follow up with the EP cardiologist, the electrophysiology cardiologist. I kid you not. Not making this stuff up. Now let's look at this strip on the bottom. But before we do, what if I had a patient in this SVT on the top with a rate of 180 and they were only mildly symptomatic? Now I feel a little something in my chest, but no, I'm okay. And the pressure's still like 110. What could we do? Medication. But electricity works faster than meds. So when somebody's super duper symptomatic, let's go for the electricity. And I'm not talking about with sinus brady and transcutaneous pacing. I'm not talking about that. I'm referring to a fast rhythm. When you're crazy symptomatic, electricity works faster than meds. But the medication for this would be adenosine, and the dose would be 6 milligrams. The doc would order that. I would give it. Note to self, adenosine, it causes a temporary asystole. I'm like, oh my God. That's not good. But it pops back up. Trust me. You just have to trust me. If the 6 of adenosine didn't work, the doc may order 12 milligrams of adenosine. And in the old days, which wasn't that long ago, it was 6, 12, and 12. But I recently recertified with Scott Stein, my ACLS, and he said, nope, that second 12 milligrams is a gone pecan. I'm like, all right, it ain't there no more. So SVT, if they're not super duper symptomatic, adenosine is our drug. But if they are super duper symptomatic, cardioversion. But by all means, talk to them and tell them the vagal. Let's look at this paroxysmal. What I want to illustrate here is this. You know all those different methods to calculate the heart rate? Well, they come in handy because check this out. Even the R on the heavy black line, like 300, 150, 100. This heart, let's see. 300, 150, 175. This heart rate went from 75 to 150 like on a dime. So they might literally say, oh, I felt my heart skip a beat. Kind of crazy. Very rapid rate. Paroxysmal. Suddenly started. Hey, and by the way, the P waves, man, it's so doggone fast. They're hard to see. They're hard to see. They might even be buried within the QRS. Causes for paroxysmal SVT, caffeine, nicotine, fatigue, alcohol. So be good to your bodies. Don't abuse yourselves. Significance, it's a really fast rhythm, and we really want to slow down a fast rhythm. So remember, treatment's going to be determined by how symptomatic. If they're crazy symptomatic, they need cardioversion. But if they're not, adenosine is our drug. All right. Symptoms. Palpitations may come on suddenly, certainly may become hemodynamically unstable, which means my blood pressure is going down the toilet. But if it's stable, by all means, try your vagal. We nurses, the vagals that we can use are cough, bear down like you're having a bowel movement. Honestly, never have I told a patient to get out of the bed and squat on the floor, nor have I submerged their face in a bucket of ice water, but never say never. Now, only a doctor can do carotid massage, and they would not want to do that on an older patient, and they certainly wouldn't want to do it bilaterally. So adenosine, 6 milligrams, little saline chase, repeat the adenosine with 12. Remember, it causes a temporary asystole, but it'll pop back up. If adenosine for any reason is contraindicated, the doctor may order different things. Verapamil is a calcium channel blocker called isoptin, beta blocker, calcium channel blocker, or even DIG. But if it's unstable, here comes our interventions for the cardioversion. You know, O2 if it's needed, a good patent IV, they're on the monitor. You know, meds if they're not an option, and the doc does want to do the cardioversion, the CRNA is at that bedside and they're given a little sedation. The doc will tell us what joules to set on the machine, and then we go from there. And it does require consent, so note to self, get the consent before they're sedated. Just a little helpful bit of information. All right, so now we've talked about sinus rhythms. We've talked about atrial rhythms in the form of AFib and SVT. And the moral of the story is, the faster that atrial rhythm, that AFib or that SVT, the goal is we got to slow that train down. So cardizem for the AFib, diltiazem, or adenosine for the SVT. Know your meds. All right, PVCs. Again, you just got out of level 3. You know the word premature means it came early. The best way to describe it is to actually look at this 6-second strip, and let's pick it apart with our systematic overview. My heart rate here is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. It's about 110. And for the most part, it's very regular, except for this guy that came early. The ones that were pretty regular had a nice uniform P wave. So this is an underlying sinus rhythm, actually sinus tach because it's rate of 110, with 2 unifocal PVCs. What does unifocal mean? It came from one focus point. They look alike. They came from the same place, but it came from the ventricle. How do I know it came from the ventricle? Because this is how a beat looks that originated in the ventricle. Let me describe it to you. It's a wide QRS, and the T wave is oppositely deflected. So regular, he came early. He's premature. That's a wide QRS. The T wave is oppositely deflected. That's a PVC. I got 2 of them. When should I worry about PVCs? When they're too frequent. When I have more than 10 in a minute. Nurses, know your units. Check your policies. I have orders to treat PVCs more than 10 in a row with lidocaine or amiodarone. So know your policies. What would I be thinking if I saw these PVCs? In a word, electrolytes. Got to know your potassium. Night nurses, draw those labs at 5. Read those labs at 6 and make a phone call at 6:05. If you're giving me a report at 7 a.m. and you're telling me that that potassium is 2.8, I'm going to say, what did Dr. Bourgeois say? Oh, I haven't called him yet. I'll say, here, give him a shout. Because you can't leave that on me. You're driving away in the parking lot and all of a sudden my patient starts to code because they got a K at 2.8. No. That's not how we roll. We got to be good to each other. We're all on the same team. So that's unifocal PVCs. Let's look at multifocal PVCs. Well, let's systematic overview. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. This heart rate's 120-ish. What do I have here? Well, this was a P wave and a good QRS. This guy came early and the QRS is wide and the T wave's oppositely deflected. And that same exact guy happened again right there. But then another premature beat happened, wide bizarre QRS complex, T wave oppositely deflected, but it's upside down of the other ones. These are upwardly deflected and this one is downwardly deflected. These PVCs came from different sites, multifocal. Check this out. What is a ventricular couplet? Well, it's 2 PVCs in a row. What's 3 PVCs in a row? It's not a triplet. It's a 3-beat run of VTAC. What's his potassium? All right, so PVCs. Here is a 6-second strip. And you see the little notched QRS? It's a little bundle branch block. No big deal. I'm not going to test you on that. This heart rate is 1, 2, 3, 4, 5, 6, 7, 80-ish. Is the patient going to do okay with heart rate of 80? Absolutely. Are they going to feel that one PVC? Probably not. Probably not. I only picked it up because I review my EKG monitors so often. We all do. So it's kind of pointy P wave, but it is nice and uniform. So this was an underlying sinus rhythm with a unifocal PVC. Why is it a premature ventricular contraction? Because it came early, the QRS is wide and bizarre, and the T wave is oppositely deflected. So the rate is 80. The rhythm is irregular because of that premature beat. A PVC does not have a P wave because it didn't come from the SA node. It didn't come from the atria at all. So there's no PR to measure right there. That QRS is wide. And I'd measure it right there. Smack in between there. See the pointy point? Go right in there to measure it. All right. PVCs can have patterns too, just like the atrial bigeminy and stuff. If you had every other beat was a PVC, it would be called ventricular bigeminy. If every third beat was a PVC, trigeminy. If every fourth beat was a PVC, ventricular quadrigeminy, and I have that for you down here. I am not so worried about patterns. I'm just not. I'm going to continue to monitor it, but I'm not. I'll look at the labs. The labs are normal. I am not worried about atrial bigeminy, atrial trigeminy, or atrial quadrigeminy. I am not. All right. So I'd continue to monitor it. Again, there's all your causative factors, digitoxicity. May be symptomatic, or they may start to feel a little something, something. The antiarrhythmic meds that you need to learn are amiodarone and lidocaine. Amiodarone's a great drug. It came out in the year 2000. I'd already been a nurse 18 years by then. So I was mad because I loved lidocaine, and amiodarone in essence replaced lidocaine, which is my favorite antiarrhythmic of all times. And if you look up the mechanism of action, you'll see that these work in the angiotensin. You know, class 1A dysrhythmic, it works in phase 1 of the cardiac cycle, the sodium phase, or whatever. All right. So know your orders. If I had a bunch of PVCs, more than 10 in a row, my patient was asymptomatic, I may look at my standing orders and go ahead and give the amiodarone 150 milligrams, but I'm not going to push it fast. I'm going to put it in a little 50 ml mini bag and put it on the pump for about 10 minutes. 50 mils is my volume to be infused, but my rate, I might set it at 400. So it's going to go in pretty fast, but in 10 minutes it's in and done. And if that worked and I got rid of the PVCs, the doc very well may order a drip. You will see that when I am able to post your class handouts for Perfusion 1 on the Canvas site, I have added the amiodarone drip parameters for you, as well as the lidocaine drip. FYI right now, an amiodarone drip, it could either be mixed 900 milligrams and 500 mils, or a pre-mixed bag labeled Nexterone, 360 milligrams and 200 mils. Believe it or not, it yields the same concentration. And I tell people this in CCU all the time, my students. If I see a drip hanging on a pump and it's 33.3 mils on the pump, I'll bet my house that's amiodarone. Because amiodarone, either concentrate, it's the same concentration, 900 and 500. The doc would want to give a milligram per minute for the first 8 hours, and that the rate on the pump is 33.3 mils. Very cool. Clinical students that get me next Tuesday and Wednesday, we're going to go ahead and calculate out our most common drips that we'll see in the unit. Amiodarone is one of them. Tridil is another. Diprivan is another. Tridil, we're going to see a lot of Tridil, and we're going to see a lot of Cardizem. All right. So there's my patterns. I'm not worried about patterns. I'm not running for the amiodarone for patterns. Unifocal, they all look alike. Multifocal, they came from different ectopic foci. Another level 3 term. Ooh, Miss Garrettson, remember you kept going on and on and on and on about the QT interval. Well, this is why. If a big bad PVC hits you on the downslope of a T wave, oh my God, look, it kind of happened here. What's this? That's V-fib. Call a code. This rhythm down here, it's just, that's a ventricular couplet. All right, so that's it about PVCs. Check your electrolytes. Know your electrolyte values. VTAC, monomorphic. Look at that rhythm. Monomorphic, it is a nice, really pretty regular rhythm. Systematic overview. Well, where do I count it from, Ms. Garrettson? I always like to count it from the point. That point might be upright or downward, but here it's downwardly deflected. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. That rate's 180. That's pretty fast. How do I know my patient went into this rhythm? Well, hopefully you and I set the high rate alarm and it sounded and I heard it and I'm going in. So I'm walking into the room trying to have a good poker face like during VTAC. You got 3 scenarios here for this rhythm. You may find a patient completely awake and alert and asymptomatic. You may find them awake, but honey, I feel a little lightheaded. And when you go to touch their arm to do their manual blood pressure, they're cold and clammy. Or 3, they're looking not alive, and you check a carotid pulse for 5 seconds and they're pulseless. So this VTAC, I'm going to say door number 1, door number 2, and door number 3. Door number 3 is pulseless VTAC. We're going to treat it just like VFib, and we're going to code that patient when we get to VFib. But when you find this patient in VTAC and you discern that they have a pulse, now we're at a fork in the road. Now you've got some deciding to do. Are they symptomatic or not? If they're awake, alert, oriented, and okay, I'm not just going to sit on it. First of all, I'm going to tell them, go ahead, cough. Give me a cough. Cough like you're bearing, or bear down like you're having a bowel movement. And I'll assess their vitals, and their vitals are okay. Kelly, get Bourgeois on the phone. He's in VTAC. Likely, I'd be given that amiodarone 150 in the 50 ml bag on the pump over 10 minutes, setting the rate at 400 mils, but volume to be infused only 50. So in 10 minutes, man, it's in. And if that had a favorable outcome, then I'd be hanging that drip. Amiodarone, 900 milligrams and 500, 33.3 mils on the pump. Thank you very much. That's a milligram per minute for 8 hours. And then 8 hours after, I'm going to cut it in half, 16.7, 0.5 milligrams per minute. And are you going to be able to rattle this stuff off just like me? Absolutely. Absolutely. So, or the doc may opt for lidocaine, but they're going to go with amiodarone first. Lidocaine is great, 1 mg per kg bolus, and it's a pre-mixed drip on the code card. When we do code this year, you'll see a lidocaine drip. It's pre-mixed, 2 grams and 500. We'd first start the drip probably at 4 milligrams per minute, which would be 60 mils on the pump. And I'll show you the math in clinical. And your ICU instructors will show you that math in clinical. All right. So here we have our monomorphic VTAC. The rhythm is very, very regular. There are no P waves, no PR to measure. QRS is wide, baby. See the point? Measure it right there. Ooh, all I want you to know is it's greater than 0.12. That's all I want you to know. QT, I can't even tell where the QT is, to tell you the truth. I'm not going to ask you about causes, but R on T and a long QT, shame on us. Shame on us if we let a QT get really long without making a phone call and alerting somebody. Treatment. For VTAC without a pulse, I've already said that we're going to treat it like VFib. But if they have a pulse and they're unstable, electricity works faster than meds. So go ahead and do the synchronized cardioversion and follow those same steps previously in your handout. If they're almost out to lunch, you could try to get a consent. If they're too out of it to consent, get the wife to consent or call a family member quick and get 2 RNs on the phone, but we need a consent. If it's an emergency, 2 docs can say, we're rolling, we're doing it. But if they're stable, again, we only put on the O2 if their O2 sats are falling. They need a good IV. Amiodarone and lidocaine are our meds. And whatever bolus work, that's the drip that we hang. There you go. There's your amiodarone dose. 150 milligrams over 10 minutes. And then hang a drip at 1 milligram per minute. 33.3 mils on the pump. And the concentration is 900 milligrams in 500 mils. So there's that pretty VTAC. Look at that. What's this rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Another example of a rate of 180. Okay, it's fast. It's regular. There's no P waves. No PR to measure. See the point? Measure the QRS up here. It's wide. Wider than 0.12. Really can't figure out what in the heck is the QT. Is that it? It looks really short, to be honest. 5, 6, 7, 8, 5.32. But here's the question. Do they have a pulse? If they have a pulse, they're alive. If they don't have a pulse, they're clinically dead, and we're going to treat it like VFib and code them. And we've already talked about VTAC with a pulse that's unstable gets cardioverted. synchronized cardioverted. Now, what is this crazy guy? First off, is this going to be on my test, Miss Garrison? No, I'm not going to put this polymorphic VTAC on your test. It's called torsade de points, twisting of the points. It's French. You see, it gets big and then little, and then big and then little. Two things. What's their magnesium? How long was their QT interval? Two things set you up for disaster with torsade, and that's hypomagnesemia and a long QT interval. That's why it is so imperative for us as nurses to check our EKG intervals at 8 a.m., noon, and 4. If my 8 a.m. strip showed me a QT interval of 0.46, and my noon QT was 0.50, and my 4 p.m. QT interval was 0.54, I'm picking up the phone. But only after going in to do an assessment and get a set of vitals and calling that doc armed and ready, looking at my MAR and looking at my labs. Here's an example, real story. CCU bed C, probably a year and a half ago. A student was paired with the nurse, Wah. Wah is amazing. She's phenomenal, one of the smartest nurses I know. Patient was on an amiodarone drip, and we all noticed that that QT was stretching out. So before Wah even called Dr. Bourgeois to let him know that the QT was getting long, she stopped the amiodarone, because amiodarone will slow you down and make your QT stretch out. She called Dr. Bourgeois, and he says, how's the patient look? And she says, the patient looks fine, awake and alert, warm and dry, vitals are stable. I'm just, his QT's getting a little too long. He's like, what meds do I have the patient on? They were on an amiodarone drip. He goes, wow, I want you to stop it. She goes, I already did. Then he asked for the labs, and he asked for what other meds the patient was on. Hour and a half later, we go on up to post-conference in the ICU conference room on the 3rd floor, and we hear code blue, CCU, bed C. That guy went into torsade. He didn't die that day, but he died the day later. And it's nothing wrong that anybody did. The man had a sick heart. But I'm just telling you, nurses, keep your eyes on your EKG intervals. I'm not teaching you how to interpret these intervals just for purposes of you getting an A on your first test. I want you to carry it with you when you go and understand how important it is. All right, so this, my friends, is torsade. We could be coding this patient. Well, what do? Call a code. The first thing I'm gonna do when I call a code is I'm stay put. The first RN stays with the patient. Now, this is a dead patient here, so I'm putting the side rail down. I'm not worried about them falling out of bed. There is a CPR pedal on the bottom of the bed. I'm gonna press it, the bed's gonna go flat. I'm not a petite person, but I'm gonna get a stool and stand on it and start doing compressions really fast, greater than a rate of 100 with at least a 2-inch depth compression. It's all about good compressions. Meanwhile, back at the ranch, before I started those compressions, I confirmed that indeed there's no pulse. Kelly, call a code. I've got 2 options. I could press the code blue button on the wall, or I could not scream, but call out with vigor to my colleagues and say, call a code, this is real. Then you're gonna hear overhead, code blue, CCU, wherever you are. I'm doing compressions. Second RN arrives with the code card, plugs it into the wall. At that point, that second RN and first RN, we may put a board underneath the patient's back to make the compressions really good. So we're compressing between 2 hard surfaces, the sternum and a backboard. We're gonna place the multifunction pads on the patient, front, back, or sandwich the heart. Is torsade a rhythm that can be defibrillated? Yes, it is. We will defibrillate. 200 joules on the biphasic. Charge it up. All right, I'm clear, you're clear, we're all clear. Boom, discharge. Immediately get back to those compressions. The only time we're not compressing is when we're shocking. All right, I'm gonna continue the code later when we get to VFib, but we could be coding this patient for 30 minutes when somebody says, man, this ain't working. Somebody gets wise and says, oh my God, what's his magnesium? Well, a normal mag's 1.8 to 2.2, or around about that, right? The mag's 1.2. Shame on us for not seeing that sooner. Now, realize we're not always going to have a heads up, but get a magnesium. And what precipitated this? Possibly a low mag or a long QT. And lots of things can prolong your QT, even certain antibiotics. Google that. I challenge you to Google what meds can prolong the QT interval. You're going to be a little concerned. It's more than you think. All right. But we'll go ahead and finish that code when we get to VFib. And here we are, VFib, ventricular fibrillation. Is this real? Yep, it's real. No pulse, not breathing, clinically dead. Call a code, first RN, which is probably that patient's staff nurse. You're staying put. Get your wits about you. Put the side rail down. Hit the CPR pedal on the bottom of the bed. The bed will go flat. Step on a stool unless you're really tall. Start good compressions. Second RN arrives with the code card. VFib needs to be defibrillated. I would love to bibbity bobbity boop defibrillate you right away, but I'm not going to just wait and stand there for somebody to bring me the cart. I'm going to start compressions. Once the cart is there, we get the multifunction pads on. This is a rhythm that can be defibrillated. We are going to shock this patient. 200 joules on the biphasic, 360 on the monophasic. If you've taken ACLS and you have your little cheat sheet card, you know we can stack the shocks, but for purposes of level 4, we're going to go with 200 joules on a biphasic and 360 on a monophasic. So we shock them. Immediately resume compressions. We shock again. After the second shock, we can try our first medication, and that's going to be epinephrine. How many of you have been in a code? How many of you have observed a code? Organized chaos. Pretty interesting. There are certain roles, and what we need to strive to do is have someone maintain the airway. It's actually, usually the respiratory therapist, and they're just bagging them. That is quite adequate. And literally, we're not overventilating either. It's probably like a, one breath every 5 seconds. That would be 12 breaths a minute. That's plenty enough. So airway, someone will be given the meds. Please leave me a patent IV. Otherwise, if your patient codes, your goose is cooked. Got a couple of people to do the compressions, man, because that's work. There is a machine called the, oh my God, it's escaping me. I can envision it. Oh, I can't think of it, but it does external compressions for you. It's fabulous. We have one in the ER at East Jefferson. I cannot think of what it's called. This is going to kill me. I'll tell you next Thursday what it is. That would be lovely, but we don't have that in the unit. We have it in the ER, but we don't have it, in the unit. So I'm doing compressions alternating with another nurse. When you see somebody getting tired, say, we're going to switch next rotation, and I'll pick up the compressions. There'll be a code team leader, usually a physician. Who is this physician? It may be the cardiologist that just happened to be close by, or the ER doc that ran up to run the code. And when they arrive there, they're going to look at the nurses and they're going to say, who's in charge of this patient? And you're going to say, me. So I hope you got a good report, and I hope you went and did a good assessment on your patient, because you need to be ready to rock and roll and start talking. All right, so we're doing compressions. Help arrives. The cavalry is here. Thank God. We get a shock in. Resume compressions. Our first med is epinephrine, 1 milligram. And keep it coming every 3 to 5 minutes. There is no ceiling on the epinephrine. After the epi, are we compressing while we give that epinephrine? Absolutely, because how else would that medication get circulated? After the epi's in, I hope a colleague nurse said, I'm a thinking nurse. She's pushing that epi. She's going to need a saline flush. So not only do you hand her a saline flush, you've opened up that clear paper, took that white cap off, got that little squirt thing out of the way, and handed them that saline syringe the way that they can just do a little power flush right after that. If it's a PICC line or a right IJ triple lumen, any kind of central line, you're probably going to need 2 10 cc saline flushes. Use the IV that's most central to the patient, the 18 gauge antecubital or the right IJ or the left upper arm PICC. Not the 22 in the thumb, not the best place to have your IV access for a code. All righty. So we've given our epi while compressing. We've shocked again. Finally, after the third shock, we can now think of our antiarrhythmic amiodarone. Now, dead people get 300 of amiodarone, not the 150 in the mini bag over 10 minutes. 300 milligrams, slam it in. Slam it in, followed by a saline chase. All right, and we're compressing, and we're going to shock again. What if we shocked again and the patient converted to a normal sinus rhythm? Somebody's going to point to the monitor and be like, oh my God, he's got a rhythm. But do they have a pulse? As crazy as it sounds, we're going to resume compressions for 2 full minutes. Wait, Ms. Garrison, I just told you they got a pulse back. I know, but ACLS dictates that we resume compressions for 2 minutes. It doesn't always translate into real life, though. I'm here to tell you. I'm just saying. But and then you can bet your boots, hey, recording nurse for the code, what was the last antiarrhythmic given? It was the amiodarone. Hang that drip, baby. And what do we set the pump at for our 900 milligrams and 500? 33.3. 1 milligram per minute, please. I bet my house that's an amiodarone drip. So that's how you run a code. It's very cool. We're going to go over this again, and I want you to keep reading your handout and studying and preparing prior to class next week, and you're going to set yourself up for success. All right. And I've really tweaked your handout for next week to really be nice, and I put the drips in and all that kind of good stuff. Again, it would be ideal to shock them first, shock them fast, but I'm the first RN. I'm staying put, starting compressions while you bring me the code card. Then we'll defibrillate them. All right. There's just our strip of VFib, coarse and chaotic. There is no rate. The rhythm is coarse, chaotic, very irregular. There's no P waves. There's no PR interval. There's no QRS interval. There is no QT to measure. Name that rhythm VFib. Now let's stop and think. Defibrillation, shocking the patient, not cardioversion, that's synchronized shock. Defibrillation is indicated for 3 rhythms. What are they? 1, VFib. 2, torsade. That's that polymorphic VTAC. And 3, pulseless VTAC. We're talking lethal. We're talking dead. Lethal, lethal, lethal. Dead, dead, dead. All right. I'm going to discuss 2 more lethal rhythms right now, but they are not going to be tested on test 1, and I don't think you're going to see them on NCLEX. But just in case, let's go over them. The first one is asystole. Every time I say the word asystole, I could cry because my dad died August 14th, 2001, and his last rhythm was asystole. And that's what I think about. And that's when you hear that sound, and that's the end of the road. We're done. Asystole means without contraction. Now, look at this strip. You see, it almost looks like a fine V-fib at the beginning, but then it goes flatline. You've got to check a second lead in asystole, because if it were to be V-fib, we could code you for an hour and a half. The questions were raised, excellent questions. How long do we code a patient for, Ms. Garrison? It depends on the patient and doc and the team. I've been in codes that lasted 3 hours. We've emptied 2 code carts, and I've been in codes that lasted 10 minutes. You know, asystole is not a shockable rhythm. So there's not a whole heck of a lot we can do for asystole. There is no heart rate. The rhythm is flatline. There's no P waves, no QRS, no intervals to measure. They're dead. Check a second lead. Start compressions. Do call a code. Start compressions. But when that code card arrives, is this a shockable rhythm? Nope, it's not. It's not even a paceable rhythm. Well, heck, I got nowhere else to go, you know? But the doc is going to appear. Who's this doc again? It could be the ER physician, could be a neighboring cardiologist. Hey, who's the nurse that has this patient? That would be me. What's going on? And I start to tell them the story. And then we have a meeting of the minds. We start exploring what in the heck could be happening here. Let's look at the 5 H's and the 5 T's. 5 H's. It could be a hydrogen ion excess, like they're crazy acidotic. Mark Stackhausen on Monday during the Dysrhythmia review brought up an excellent point. He goes, Ms. Garrettson, we were texting. Students had access to my cell number, as you all do probably, and that's great. They texted me the questions, and then I was, speaking out loud, saying what the question was. I've seen bicarb used in a code. Absolutely. When we have documented acidosis, we give bicarb. But in the old days, we were just randomly giving bicarb to everybody and their grandma, and we were killing them off more alkalotic. So we only give the bicarb if they're acidotic. It could be hyper or hypokalemia. Again, I cannot stress the importance of electrolytes enough. Hypovolemia, hypothermia. This is when the doc's going to say, well, okay, hang 500 of saline and let her rip. Or somebody get a temp. How cold is this? Get the warming blanket or whatever. Hypoxia. We're bagging them, of course, in the code. The 5 T's, cardiac tamponade. Miss Ian Neely is going to cover pericarditis, the inflammation exemplar. And it'll be cool. She's going to talk about cardiac tamponade. The pericardial sac just sits around the heart, inside of which is just a little lubricating fluid. It shouldn't have a blanket of blood squishing the 4 chambers. But if that were the case, the doc would have to do a pericardial synthesis and remove that blanket of blood and allow the heart to beat. Could be tablets, a drug overdose, or a clot, a thrombosis to the lungs, a pulmonary embolus sitting in the pulmonary artery, or a clot in a coronary artery causing an MI, a myocardial infarction. Ms. Dickerson is going to talk about tension pneumothorax and oxygenation too. And that's cool, man, where you have a pneumothorax, a tension pneumothorax that is so severe, it's literally causing tracheal deviation to the opposite side. So if you had tracheal deviation on the left, you got a right-sided tension pneumo. And they need a needle thoracostomy, second intercostal space. And I ain't going to do it either because I'm an RN and it's not within my scope of practice. But it's cool to watch. So there's not a whole heck of a lot that we can do, guys. We're having a meeting of the minds. We're compressing, but we're not shocking. It's not a paceable rhythm. We can try the epi and keep it coming every 3 to 5 minutes. And that's all she wrote for asystole. Now, PEA, we have a little more hope. And I'll tell you why. Because they've got a rhythm, but they have no pulse. It could be a narrow complex rhythm or a wide complex rhythm. It could be faster or slower. A student, again, asked an excellent question. Well, Ms. Garrettson, this looks like normal sinus rhythm to me. How would I even know that this was PEA? Well, you know what? You'd find a patient, well, sadly, man, if they weren't on the monitor, you'd really be in trouble because you'd walk in and they'd be dead. And you'd shake and shout and they look blue around the gills and you're like, oh my God, what's going on? But PEA in the unit on a monitored patient, the high rate alarm wouldn't sound, but you know what would? The pulse ox. I'd say, why is my pulse ox sat in 70%? Let me go check this out. And I go in and he's looking kind of dead. You all right? You all right? Oh my God, this is PEA. Kelly, call a code. Hit the code button, bedside rail goes down, hit the CPR button, bed goes flat, step on that stool and start those compressions. Now, PEA, just like asystole, is not a shockable rhythm either. But when we're exploring the 5 H's and the 5 T's now I've got more of a shot that they're going to respond. Picture that cardiac tamponade. Once that doc removes that blanket of blood, those 4 chambers, boom, 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 can beat again. Just saying. Or when that tension pneumo, that air escapes, relieving that tension pneumo, then, it's not going to put so much pressure on the heart. So explore those 5 H's and 5 T's. The doc's going to start calling out stuff. Get some ABGs. Are they acidotic? Give the bicarb. Give a 500 cc normal saline bolus. All right. Now, a word about heart blocks. Just FYI for anybody that wants to work with monitored patients after you graduate. Heart blocks are not going to be on your boards, and they're not going to be on test 1 or the final. Heart blocks, there's first degree heart block. There's second degree heart block type 1 called Mobitz 1. There's second degree heart block type 2 or Mobitz 2. And there's third degree heart block. So first degree, second degree Mobitz 1, which is also called Winky-Bach, second degree type 2, and third degree. First degree heart block. Look at this strip. It's a 6-second strip. My heart rate is 50. It's a very regular rhythm. I've got nice uniform P waves. But what? When I measure that PR interval from the beginning of the P wave to the beginning of the QRS, it's consistently long. It's 0.24, 0.24, 0.24, 0.24. It's first degree heart block. Heart blocks are like relationships. First degree, you just need a little space from each other. Continue to watch it. One thing that I would glance at is what meds do we have this patient on? Oh, 50 metoprolol BID. Maybe before my next dose, I'd let the doc know and ask them what you want me to do. All right, but it's certainly not an emergency. Now let's look at second degree heart block type 1, Mobitz 1, Winky-Bach, named after the doctor, Dr. Winky-Bach, who discovered it. The PR interval gets longer, longer, longer till you drop a QRS. I'm not going to lie to you. This is not the best example of Winky-Bach, but you can see that I had a long PR interval. This one's longer. And then finally, I kind of get a P wave right there superimposed on the T, and I don't get a QRS. And it repeats itself. Longer, longer drop. Longer, longer, longer drop. Oh my God, Winky-Bach. It's a pattern. I'm not so worried about the pattern. Just like first degree, I'm looking at the MAR. What meds do we have this patient on? You know, maybe, you know, I'll let the doc know. But it's not an emergency. So thus far, there's really been no treatment other than maybe to be a thinking nurse and to have a conversation about holding a beta blocker that's due. Let's look at Mobitz 2. In this example of Mobitz 2, I see a heart rate of 50. In this example, it is a very regular rhythm. And I do have nice uniform P waves. In fact, that's a P wave, that's a P wave, that's a P wave, P wave, P wave. But when I do have the P that's talking to the QRS, that interval is fixed. That's what differentiates this from third degree. But unlike first degree and second degree type 1, now I'm worried. Now I'm worried. Even though they may be asymptomatic, the doc needs to know about this Mobitz 2. Meds need to be adjusted. It is highly likely this patient's going to go home with a permanent pacemaker. It's highly likely, highly likely. So heart blocks are like relationships, the husband, whoever doesn't come home every night, but when they come home, then they're talking to you, but they don't come home every night. Yeah, that's a problem. Now, third degree, my friends, divorced. The P waves are living their life. The QRSs are living their life. In fact, the P waves may literally march right through the QRS. But when you look at the PR intervals, they're all over the place. Well, that's kind of normal. That's really long. Whoa, that's crazy long. What? Divorced. The P's and the QRSs ain't talking to each other anymore. The P's literally march right through the QRSs. Again, they're probably going to the cath lab for a pacemaker. Now, I have seen lots of patients in third degree heart block. Little old ladies with a heart rate of 32. sitting in their bed, watching The Price is Right, asymptomatic, awaiting their turn to go to the cath lab for their permanent pacemaker insertion. Kid you not, it's crazy. But you can't send somebody home in third-degree heart block. They need a permanent pacemaker. Next week and the following week in class, you'll see on the Canvas site, once I'm able to post it, that you have a pacemaker teaching sheet and an education sheet that you need to know up, down, and all around. Somebody can get a permanent pacemaker inserted. Does anybody have a loved one, like their grandmother or maybe even a parent with a pacemaker? They can live a phenomenal, wonderful, awesome life. You can use the microwave. You can use your cell phone, just hold it on the other side. Typically, the pacemaker will be implanted on the left because that's where the heart is. And the doc will insert wires and maybe one wire, maybe two, maybe three, depending on what type of pacemaker. You are not responsible for knowing heart blocks or the pacemaker rhythms that I'm about to show you. But in clinical, you're going to see pacemaker rhythms. So I just want to give you a heads up. But before we get to that, let's finish talking about third degree. Significance, very dangerous. Upstairs and downstairs are not communicating, the atria and the ventricles, the P wave and the QRS. You could maybe try to transcutaneously pace them, but you could try that, and they're going to go home with a permanent, but that's it. Symptoms, you know what a symptomatic patient looks like. Honey, I feel lightheaded. I'm cold and clammy. I'm short of breath. Treatment, got to get that transcutaneous on while you're awaiting permanent pacemaker insertion. Rarely they would start a dopamine or an epi drip, not often. So let's stop and think. To help differentiate between the different types of heart blocks, we look at the PR interval. In first degree heart block, that is C, consistently long. So put a little number 1 there. Second degree heart block type 1, that's your Winky Bach. Longer, longer, longer drop. Oh my God, Winky Bach. So that's A. The PR interval gets longer, 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 and you drop a QRS. Number 3, second degree heart block type 2, Mobitz 2. When a PR is present, it is fixed. And last but not least, third degree heart block, what would be going on with that PR interval? All over the place. All over the place. They're divorced. Paced rhythms. See the pacer spike? Well, that's before the little bitty P wave, and then the QRS followed through. Little wide conduction there, but it followed through. But look at this guy, ventricular paced rhythm. I'm not going to test you on this, but you're going to see this in clinical. I'm here to tell you, you are going to see this in clinical. This is a beautiful rhythm. It is 100% ventricular paced. This is a 6-second strip. My heart rate is 70. 1, 2, 3, 4, 5, 6, 80. I'm sorry, it's 80. Or maybe it's not quite a 6-second strip. It's about 70. I think it's longer than a 6-second strip. Very regular. Pacer spike. Whoa, look at that. It's a wide QRS with the T wave oppositely deflected. Man, that sure does look like a ventricular rhythm. It is. That's where the wire is. The doc put the wire in the right ventricle, and that's the rhythm that we get. So how you like that? It has 100% capture, meaning I see the pacer spike and I get a good QRS. Correlate it with the patient's pulse. How are they looking? An excellent question was asked on Monday. Ms. Garrettson, how do I know the patient's pacemaker is working? Look at their perfusion status. Are they symptomatic or not? Who are we treating, the monitor or the patient? We're treating the patient. Are they perfusing? Awake, alert, oriented. Warm and dry. Blood pressure stable. Making good urine. Not short of breath. No chest pain. Remember, if you can ambulate, cerebrate, and urinate, you're perfusing. But guess what? Sometimes things go wrong. You're like, uh-oh. Failure to capture. Oh man, that doesn't sound good. Dang, I got a pacer spike with nothing behind it. Well, dude, that's almost not skipping a couple of beats there. Check your patient. How they doing? They're probably doing all right, but still we need to think about what the heck is going on there. Maybe we need to increase the juice, the milliamps. Maybe check the wire Well, the doc would have to check the wire, not me and you, because that's on the inside of the heart. Maybe the battery's getting a little low. A permanent pacemaker insertion, it's housed in a pulse generator underneath the sub-Q layer of skin. But that battery's going to need to be changed every 5 to 10 years, and that's a whole nother surgical procedure. And then they make all kinds of different pacemakers. To mimic more of our normal cardiac function, the doc can put in a pacemaker with 2 pacing wires, one for the atria and one for the ventricles. So check it out. I got 2 pacer spikes. You're not going to have this on test 1. You may see this in clinical. What I would call this is 100% AV sequential pacemaker. Boom. Most importantly, how does the patient look? Are they perfusing? Are they awake and alert, warm and dry, with a stable blood pressure and denying symptoms? Again, the benefit to an AV sequential pacemaker, hey man, we got our atrial kickback, because when we only have something that's contracting the ventricles, I don't have my atrial kick. That's 20 to 30% of that cardiac output. Something to think about. All right. All right, my friends. This is going to conclude the recording of the Dysrhythmia review. I encourage every level 4 student to go over it a couple of times before the next 2 weeks. You're going to have different handouts. They're going to overlap and be very similar, but they're going to be 2 separate handouts. Next week, next Thursday and Friday, I'll do 1 hour starting with your 10-question quiz that we're going to have. Well, that's our ticket to class. So I look forward to doing that with all of you. All right, have a great, enjoy your last week of freedom, my friends. It's not next week, let's see. It's not next week, sorry. It's on the, class will be on the 20th, so you got a couple of more weeks. But those of you that have 12-hour clinicals, remember orientation is going to start on the 18th and the 19th. And your teachers will be getting a hold of you. Anybody that's a student in my clinical group, I'll be getting in touch with you mighty, mighty soon. All right, thank you for your attention. Please find the eval on Canvas that was sent to you, and please send your feedback. I really appreciate it, and I learned from it, and it'll improve for our future classes. Y'all have a good couple of weeks, and I'll see you soon. Thanks. All right, turning it off.